welcome back to the channel. So today it's going to be a little bit different. I put together a Zoom session to talk about OB-GYN, and I have two special guests to help me. Grant Vaness, which is our fourth year classmate of mine, and you guys all know him from my previous videos, so he's going to help us with that. And then I have a College of Medicine from Arizona, Tucson, Richard Martirosian, who is also going to chime in and talk about OB-GYN. So this is going to be the recording, and everyone got to ask questions, and we went over a couple of aspects that I thought were super important for this rotation. So I hope you guys enjoy it, and definitely post any questions, like, comment, and subscribe. Thank you.
I just did my OB rotation, so feel free to ask any questions, and I'm excited to see what Jasmine prepared for us.
Okay, so I just started recording, so this will be going on my channel. All right, sweet. So OB-GYN, what is it? So it stands for this really big three words: obstetrics and gynecology. And it's essentially dealing with everything about the female anatomy. And it's not just taking care of pregnant people. We take care of literally all types of women who aren't pregnant, who are pregnant, who want to be pregnant, who are past their time for getting pregnant. We deal with all of that. I don't know if Richard and Grant, if you guys have any other say in that, but I know some people, when they talk about OB-GYN, you automatically think pregnant people, but it's essentially all types of women.
Yeah, I do want to mention quickly because, you know, it's interesting, the distinction is obstetrics and gynecology. I'm not sure if you're going to get into this, but maybe explain what obstetrics is versus what gynecology is, because it kind of gives the difference between, that's the thing that's important to.
Yeah, so it's definitely a really big difference. Obstetrics is going to be dealing with the pregnant females. That's going to be people who are planning to get pregnant, who are in the midst of having their baby, and then after pregnancy as well, having to do all of those exams, and checking in on the baby and mom and seeing how they're doing. Gynecology is going to be things that revolve around menstrual cycles, breast exams, just kind of like the female anatomy wellness, and things like that. So what else do you guys have to put in?
Yeah, I mean, I think obstetrics is kind of relating to the actual delivery process, which is a big part of what OB-GYNs do. But the gynecology is like the women visits, those types of things that women go to all their life. So, you know, there are some providers that in the OB-GYN world will do primarily just obstetrics, and some just do primarily gynecology. Most of them do a combination of both, but there are avenues you can take if you have a particular area of interest within the field, so within women's health.
Yeah, that's all true. Another thing that is very special about OB-GYN, some people will fight this, but I think it is a surgical specialty. They do their own surgeries, whether that's in obstetrics when you're doing C-sections, which is considered a surgical procedure, or if you're doing like gynecology surgery, where you have females with cancers of the uterus or things like that, or when you're taking out a uterus, you do a hysterectomy. That's all under the knife. That's all a surgical process. So obstetrics and gynecology also has a surgical aspect if you like surgery, and it also has a lot of like the primary care practice where you're talking to patients about birth control and doing a lot of preventative health as well. So it's very, very interesting. It has a little bit of everything, I feel like. Cool. Does anyone else have anything to add?
Jasmine.
Hi, Grandma.
Am I supposed to be on?
No, there's a mute button right there. That's it.
Jasmine, get home.
Okay, guys, this is my grandma. So I put together some talking points for us, and for like my other medical students to talk about as well. So most memorable experience that you guys have had. If you guys want to start talking about that, I don't know who wants to go first.
For most memorable, definitely delivery. That was a crazy experience. So yeah, that was definitely something I didn't expect to see when I started med school, and it was really crazy to see it. So that's definitely something really cool about the rotation. Some of the things I didn't like, I mean, that just kind of varies with where you do your rotation, who you work with. But overall, it wasn't something I'm necessarily interested in, so that I didn't really like. But overall, it was a great experience. Saw a lot of cool things, like the deliveries and some of the surgeries she was talking about. What do medical students do? They do pretty much everything. I mean, other than actually doing the surgeries and some of the actual procedures, we try to do as much as possible. And if the residents are good, they'll let you do a lot more and just kind of watch you. So you do a lot as a medical student. You're definitely in there for the deliveries and C-sections and all the surgery. So a lot of cool things to see.
Cool. Thanks. I won't talk about my most memorable experience just yet. It kind of goes off the delivery portion. I'm going to talk very much in depth about a C-section later on at the end, because that was just mind blowing when I saw it. But Grant, do you have any memorable experiences?
I think that, you know, more so than, you know, the procedural things that are done and from the medical side of things as a provider, you know, you have a lot of neat experiences about things that you personally get to see and do. But I think that the most memorable things for me was, you know, the look on a mother's face when she sees her baby for the first time, especially if she's a first-time mom. It's kind of a special moment. Or, you know, when a baby takes his or her first breath and first cry. Those kinds of things are kind of special moments you get to experience, that, you know, you wouldn't be able to see unless it was, you know, you're working as an OBGYN or it's your child. So it's really kind of a cool thing you get to share in. And I think that, you know, just quickly being able to form relationships with these moms in delivery, going through, you know, what's a really painful process and try to be an advocate for them and cheer them on. And those types of things can make your experience a lot more memorable for you as a student. You know, you really put emotions to the event, and to see kind of the appreciation that the mothers have to you as a provider, even though you're just a med student, and how thankful they are for you being there is pretty special. So I think a lot of those things make OBGYN a really interesting field.
Yeah, so that's all very true. And again, so med students are very much a part of the delivery process. They, as you can see this picture here, they have a lot of models where they have us practice delivering a vaginal delivery baby. And so on a mannequin, and they will teach you how to grab it, how to orient it through the vaginal canal and take it up safely. So there's a lot of stuff that goes on with that. And then they do prepare us a little bit for a C-section, not so much. That's why I'm going to talk about it at the end of the day, or at the end of this PowerPoint, because I was completely taken aback when I was in my C-section as a medical student. And so I kind of want to prepare you guys a little bit better than what I was prepared for. So things you disliked about the rotation specialty, I'll start. I do not like the surgical aspect of OB-GYN, but that's just personally. I don't like surgical specialties. The hours are very long. The residents work very long hours. Of course, all residents do, but I feel like their residency has more long hours than others. Other than that, I mean, most of the residents I noticed and most of the attendings were female. So you will be surrounded by a majority of females. There was, again, a couple of male residents who were there. But those are my things that I kind of didn't really like about the rotation, and that I noticed, but I don't know, Grant, if you have anything else to add.
Yeah, I don't know. I think one of the challenges of being an OBGYN is dealing with especially mothers that aren't doing the things that they need to do to make sure that their pregnancy is healthy. And you know that the majority of mothers do, but it's challenging when you have those that don't. And you know, you can sometimes have a sense of helplessness in a situation. And you know, there are two lives potentially at stake, depending on how well they take care of themselves. And it's hard sometimes to impress upon them the importance of proper diet and those types of things. So I think that's a definite challenge that OBGYNs have. And you know, getting patients to continue to follow up to clinic, you know, it takes, you know, really routine visits to make sure that they're progressing appropriately down their delivery. And sometimes it can be really disheartening when there's, you know, inadequate follow-up, those types of things. So that's something that I think would be a challenge.
Yeah, that's also very, very true. Things that I enjoyed about this specialty or the rotation. Mostly like when I got to interact with the babies being born. One thing I liked about it is OB-GYNs were doing a lot of birth control implants, whether that was IUDs or like a Nexplanon arm implant that goes here. They do that. It's super, super cool. I like that they would do that like in clinic or in the office or right after having their baby. And it's really fun to watch. And they're just small little procedures that a lot of the OB-GYNs do. Like this arm implant takes about 20 minutes. The IUD insertion takes about 20 minutes. So just little procedures like that I thought were really fun, and it gives you a lot of variety in your day. So you're not just doing the same thing over and over again. There's so many different things OB-GYNs do. Grant, do you have anything for that bullet point?
I was gonna say, I totally agree that I think that the big draw is the variety that you get in OBGYN, you know, from clinic to deliveries to surgery, you know, they have it all. And I was also just going to mention about dislikes. You know, depending on who you are, if it's a like or a dislike, OBGYNs have an entirely different language than the rest of medicine. And, you know, it can be challenging to figure out their acronyms, figure out the way that they communicate with each other. And that kind of carries over with, you know, it's difficult. As a med student, you're taught how to, you know, write notes in a particular way, but they do things very, very, very differently in that specialty. So there's a learning curve to getting used to communicating in both verbally and electronically with each other in OB. So.
Yeah. And for this next one, what do medical students do on the team? Richard, you can kind of chime in on this one too. I kind of want to talk about what medical students' job is. So like, for example, in a C-section, the medical student's job is to hold what's called the bladder protector or something like that, where essentially it's this metal piece that goes right over the bladder to kind of protect it. Because when you're doing a C-section, you're cutting through a lot of stuff to get to the uterus, to get the baby. And so you have to protect that bladder, and that's our job. And it's super important because if the bladder gets cut, that's going to cause a whole other issue. We're going to have to get urology in there, and mom's not going to be happy because we cut her bladder. So it's super, super important in the OR that you're holding that bladder protector. I don't know what they did at Arizona, if they did anything different. I'm sure Richard can talk about that. We also did, let's see, our job was to make, like, you know, suture some sutures up. I don't know, Grant, did they make you do anything else?
Yeah. So the bladder retractor is really important, and you know, to that point too, that the mom's also awake. So you know, if you do something, if you mess up, it's even more challenging because you know she's awake during the procedure. So definitely make sure that you're doing your job well. But yeah, I mean, aside from the suturing at the end, they let me pull the placenta and try to remove the placenta as well,
That's
which
a
was
good point.
other part. So
Yeah.
Yeah, and then outside of the surgeries, you do a lot more. You're always the first one to see the patient, so they do rely on you to speak to the patient, see what's going on, ask good questions, take a good history. So you're definitely a piece of the team, or at least that's the way it should be. And yeah, you do get to test out the things you learn and see if you can figure out what's going on with the patient. And the residents really do push you to try to think about those types of things. So the surgeries you get to do less, but I mean, that kind of makes sense. You don't have the training necessarily to do everything. They still try to get you involved with some of the stuff you guys mentioned. For our school, they really tried to give us as many opportunities to deliver the placenta. So after you deliver the baby, within the next few minutes, you want to deliver the placenta. I don't know if we're going to get into some of these things, but it's actually really important because it could cause a lot of bleeding and a lot of problems. So it's actually a pretty big job. And luckily, it's kind of when everything is already happening, the mom's usually distracted with the baby and stuff. So they're more okay with you doing some more things. So that's a cool experience. And yeah, seeing a placenta is very interesting. It's not something you're going to get to see, you know, unless you're in the medical field, or maybe if you're in there with your family or something. But that's definitely a big part of a medical student's job, delivering placentas. Yeah.
Yeah, two of the big jobs that you guys will do is deliver the placenta, again, which is it's a really big looking red thing. It looks like a bloody steak that just comes out of mom, and we deliver it. We basically clamp the cord that's outside the vagina, and then we slowly pull that cord so that little by little it comes off, and then it all just comes out. And you make sure that all of the parts are there so that there's no missing pieces inside the uterus. And then again, the bladder retractor is super important job. Another job that we get to do is pap smears. So we get to do pap smears. Again, we do those on 21-year-old females. And we do those every 3 years to screen for cervical cancer. Those were really fun. So I won't go into any more details about that. We do take the fetal heart tones, where we take a little ultrasound, we put some gel on it, and we go and we get that the baby's heart rate, and we measure it and make sure it's normal. We can also measure the fundal height, which is how big mom's uterus is, which can tell us how old or how many weeks she is. We just want to make sure that she's tracking along, and she's not small in size or too large in size, because those can mean different things going on with baby. So a lot of stuff the medical students get to do. I don't think I know anybody who ever put in an IUD. In terms of an epidural, that's an anesthesiologist job. And it's very, very, very dangerous because you're putting something into the spine. And so I don't think medical students are very much trained to do that. So we leave those to the anesthesiologist. I was never able to do this, but I think we measure magnesium levels for some patients. I was never able to do that, but I hear some people were. So that's something you do, because patients will be on magnesium for something called preeclampsia, which is something that it can lead to even worse things and can cause mom to die as well. Sweet. So we talked about a lot of things. Any tips for the wards for you future medical students? I don't know, I guess just be prepared, because a lot of what I felt in OB-GYN, a lot of these things, it was the first time I was seeing them. So I must have had this look on my face, because I got asked a lot of times, like if I was okay, if I needed to step out of the room. But like a lot of this stuff, when you see them, it's kind of shocking, and there's really no way to prepare for it. Yeah, we use the mannequins to prepare for vaginal deliveries and things like that, but that doesn't really compare to the stuff you see when you're actually there on a real live person. The OR will smell like blood. It's very, very crazy. There are so many fluids everywhere during pregnancy, during C-section. And in the OR during a C-section, you can smell the blood. It's really disgusting. Again, you have masks and stuff like that, but it is very bodily fluid heavy, I feel like. So prepare for that. Don't wear nice shoes. Oh, another thing I didn't talk about, another thing that I liked is that during vaginal delivery, the medical students get to help out with different positionings of the feet of the mom, because when they're when they're delivering and they're in labor, sometimes baby doesn't want to come out, and sometimes mom is having a hard time pushing. So actually, I was able to play tug of war with a mom with a blanket, and she would pull and I would pull, and that would kind of help her push a lot stronger. So little things like that made the rotation fun for me. But we'll move on. Those were some good talking points. Again, if you guys have questions, you guys can always put them in the chat. Skip one. Okay, so C-sections. I want to talk about C-sections a little more in detail. Before we talk about this, though, I will warn you that there are pictures that I put in this PowerPoint that depicts steps of the C-section, and they're going to be exactly what you'll see in the operating room. So if you don't like blood or anything of that nature, maybe like just don't look or something. But I am really excited to talk about this. So what is a C-section? Essentially, this is going to be another form of delivering the baby that's not vaginally. So this is a C-section scar, and you can see some staples there, and you just make a cut right below mom's bikini line, and we essentially dig in and find the uterus and deliver the baby through that incision. Grant, Richard, do you guys have any other things you want to say about C-section?
I mean, just a couple of things. There are two ways to do a C-section. One of them is what is this horizontal line that we have in this photo that Jasmine was mentioning. The other one is to actually do it vertically. The vertical direction, actually, you can do these C-sections faster. If it's a real tremendous emergency, you can get the baby out quicker. But cosmetically, it's not the preferred outcome. And that direction of the suture tends to tear more with the stress of moving your abdomen. So if possible, they always like to go for the horizontal suture. But just wanted to mention that as an alternative.
Yeah, that is true. So indications for a C-section, again, if baby's heart rate is dropping, that means we got to get in there and get baby out fast. So we don't have time to be doing the whole pushing and the laboring, because that can take hours. So if baby's heart rate is too slow, that's an indication to get in there and get baby out. If baby isn't doing well during labor, so if mom is having a vaginal delivery and during the vaginal delivery, baby's heart rate's slowing down, and you're seeing that the baby's not doing well, we'll go straight to the OR and we'll roll her back and we'll start the C-section. If baby is in a breech position, so we like babies to be head down, because that kind of engages the pelvis and the vagina to kind of open up to allow baby to pass through. So if the feet are down, that's not going to do any good. So there are a couple of things we can do. We can actually try to manipulate baby and push it so that its head is facing down, and we can do that by moving it on the outside. Or if it's just not happening, we go to C-section and we take it out that way. If mom has an infection in her vagina or her cervix, we don't want baby to go through that, because there's going to be an infection there. So we'll go in and do a C-section. If mom is losing a lot of blood, or if she's hemodynamically unstable, so her blood pressure is not good, her heart rate's not good, her breathing's not good, we'll go to C-section, just because we can control more things during a C-section than a vaginal delivery. Again, if mom has had a C-section in the past with her previous kids, there are certain steps we can determine whether or not she can have a vaginal delivery. But if she has one, she'll most likely want to get one again, because if she tries to push and things like that with the C-section scar, it can rip open, and that won't be good. And then again, you can get a C-section if you want one. So if mom wants a C-section, there's really no reason why she cannot have one. And then what happens during a C-section, that's going to come up in the next slides. Grant, Richard, do you have anything to ask before we go on?
Yeah, so usually the C-section isn't like the preferred way. It's obviously safer to do it naturally through. So doctors don't usually like recommend or try to convince you to do a C-section unless there is one of those like indications she mentioned. And yeah, generally, unless you specifically want it, they're gonna do whatever it takes to have the baby delivered vaginally. And some interesting things happen even with like twins. They might even deliver one vaginally if it's possible, and then maybe the second one, they'll still do a C-section. So it definitely, the preferred method and the safer method overall is the vaginal delivery, but the C-section is sometimes needed because you never know, the baby might have to come out now. And like Grant said, they might have to go through a vertical cut and just get the baby out. So very interesting stuff.
All right, guys, we have about 7 minutes left, so I'm going to go through these C-section photos really quickly. You guys can, again, ask questions as you feel. All right, let's do it. So, again, this is a surgical procedure. You're in the OR. You're going to have an anesthesiologist, a bunch of nurses, going to be a bunch of people. It's a little traumatic. It's a little nerve-wracking. But you do have this sheet that goes over mom, so mom doesn't see or feel anything below, like, her nipple line or anything like that. So she really has no idea what's going on the other side of the curtain, but this is what mom will see. All right, so this first picture is what the resident and the attending will do. They'll make a transverse incision, we'll go through that fat, and eventually you'll get to the abdominal muscles, which are right there, and we'll essentially just do this, and we'll just spread them out and rip those so that you can get behind the muscles, because the uterus is behind that. That's essentially what they're doing. And then there you go, you get the uterus. And that uterus is going to be that big bulging pink thing. It looks really vascular, right? It's got a lot of blood flow going to it. And then if you see that little metal thing right there, that's on the bottom that someone's holding, that is the bladder retractor. And that is what you as a medical student will be holding the entire time. So work on your wrist muscles. So there's that. All right, and then essentially you'll cut through that uterus and you'll get baby out. There's gonna be a gush of fluid. Again, it's gonna be super, super bloody in there. That's just because the uterus is very vascular. It's got a lot of blood vessels going towards it. So get baby out. And this right picture is gonna be the uterus after you get baby out. So again, you can see that there's a cut there that we made. And it's really crazy because guess what? You get the uterus and you bring it outside of the body, which is just mind-blowing for me. So the uterus is just chilling outside the body, you know, and you just hold on to it with a sterile sort of towel, and the OB-GYNs will start stitching it up. And essentially we'll put it back in mom in a place where it's supposed to be. And you can see those stitches, and that will heal over time, but you can see why we prefer a C-section if you've already had one, because if you push and that scar burst open, your uterus is essentially going to just be in pieces. So, and then there you go, you have baby. I don't know who this family is, but I found it online and it looked really happy, so I put them in here. And then you just got this scar that mom has. But other than that, that's a C-section, and it's really awesome. So last 5 minutes, guys, I want to open it up to questions. But thank you guys for being here with me and my two guest speakers. If you have any other questions about OB-GYN, please let me know and ask questions. This video, again, will be up on my channel if you have people who didn't get to see it. So thanks for coming, everyone. We will be on here for the next 4 minutes and 20 seconds if anyone has questions. let's see, stop share. All right. So first question is, are there any pros to the C-section? Because you said some people prefer it over the natural way. Yes. So having a vaginal birth is very traumatic to the muscles down there in your pelvis. Again, if you have a lot of vaginal deliveries, you can actually start having incontinence, which is where you can't hold your pee. And then things start to get very loose down there. So people will get C-sections for that reason. And then again, we talked about the other indications. Grant, Richard, if you have any others.
Yeah, what you were talking about causing those problems, those aren't common things. And it's not like if you have one vaginal delivery, everything's going to go wrong from there. So that's not really the main pro, I would say. I would say the pros are more, you choose when you want it to happen. Everything's in a more controlled environment. But it is surgery and anything can go wrong. So like we said, it's generally not the preferred method. And the thing is, if you do a couple C-sections, now you kind of have to do them from now on too. So it kind of limits your opportunities that way. But I guess some of the main advantages is the fact that you can do it under anesthesia. So if you really do have a problem with pain or you just can't handle it and you know that about yourself, that's definitely an option. And you choose when it's done. So it kind of reduces some of the anxiety of having a child.
Right. We don't have that much time here, but Grant, do you want to answer this one from Megan? Was there a disease procedure that you found most interesting or difficult to understand?
I think that an interesting procedure, we had a lady that unfortunately had pretty significant fibroids. And, ideally, when we were doing these surgeries, fibroids are kind of tumorous growths that come on the smooth muscle of the uterus. And it's interesting, a lot of times when they get big enough, you have to make big incisions to take these things out. What's nice is there's laparoscopic surgeries where they can come in with ports and look through cameras. There's some surgeons that are specialists in doing minimally invasive surgeries with cameras and port sites as opposed to large incisions. And we were able to get a fibroid, bigger than the size of a baseball out of somebody through, a small opening in the skin. So it is kind of amazing what you can do with a camera and a couple of ports. So